Are we live? Okay. Hello, everybody, and welcome to GIG's Action Planning Forum. We didn't call it a webinar because I think this is a brainstorming working group with everybody's ideas coming into play. Before I start, I'd like to thank the background girls, Madeline for organizing all of this, Kitty from Livebox, running the platform, and everybody else that has worked with that team. What we've done is we've got 11 speakers that will go through their presentations from their countries. And from there, we'll have three sections. One would be the challenges met by them. Secondly, is how they resolve some of these challenges. And thirdly, how GIGS will be able to help with its membership to bring this forward, to take these things forward. Before I go any further, I'd like to thank our partners. So Livebox has provided the platform, but we have many other collaborators who work alongside GIGS to support work for children's surgery. I've done the introduction. Emmanuel will be taking over the discussion, and there will be some thought process being relayed forward by Zippy and Doruk. And finally, we'll have a further discussion followed by conclusion. So we'll kick off firstly with what are the greatest challenges that people face. We have 11 speakers and have moved from east to west, looking at countries that had high infection with the coronavirus, so those that had peaked first. So we're starting from the Eastern Bloc, moving down to the West. I think the speakers will be introduced by themselves, so I'm not going to go through each one of them. And it is a short lightning presentation. So once the person has spoken, we will move on to the next one, and then the discussion point will take over from there.
Thank you. Hello, everyone. I'm Ken Wong from Hong Kong. I'd like to thank Marilyn for organizing this panel and forum for everyone to discuss this issue of COVID-19. I think when she asked me to come on, I was a bit surprised because in Hong Kong, we feel that we're quite lucky in the way that we don't have a big problem for COVID-19. We got sort of news about this new virus back in sort of middle of January that's from China. Because we had a visitor from Wuhan coming to Hong Kong at that time, and he sort of got to tell us about this virus. So basically, I think in Hong Kong, if you've been to Hong Kong, it's one of the most popular sort of cities in the world with almost 8 million people and all kind of this tiny sort of island in itself. So in terms of cross-infection and the risk of transmission, it would be very high for this virus. What we've learned is that we had experience from the SARS virus back in 2003. And our scientists actually in Hong Kong was the first one to discover this virus of SARS. So once we found out this new virus, this time round, our microbiologists quickly sort of went into work and studied what kind of virus it was. And quickly we found out this is coronavirus as well, similar to SARS virus. So everybody in Hong Kong was put on high alert, and if the government, everybody's like in a big sort of end of January, we were like cutting down our services, although not to the same extent as in the West. For us, ped surgeons in my hospital at least, we didn't shut down everything. We cut down our elective surgery by half only, and we try to minimize the people going to the ORs. So only one surgeon and one assistant, no more medical students, no trainees as such. And the main issue for us is the number of PPEs required to reduce the risk of infection. In fact, unlike the West, when we operate, as surgeons, we don't really sort of put on PPEs. Only the people doing like bronchoscopies and anesthesia put on PPEs. So luckily for us, over the past few months, in Hong Kong, we only had 1,000 cases and only 4 deaths and no children dying from the disease. And what we've learned is to be able to speak to the population very frankly and clearly about what's going on. So we had press conference for the government Department of Health every single day at 4 o'clock and inform the population what's going on, how many new cases. So everybody seems to be on alert. Everybody was wearing a mask in the community. So I think for us to stop the spread of the virus, at least in my place, in my community, is the sort of 98% of the population wearing sort of face masks when they go outside, unlike people in the West. What gigs can do as well is probably to involve all the sort of people around the world by doing this forum as well on a regular basis, and just to keep spreading information, let everybody know what's going on exactly. And I hope that this virus goes away. Well, probably it won't go away for a long time, but it will sort of die down sort of quickly, and maybe have some other cases over the next few months and maybe a couple of years' time. So that's all I'm going to say. Thanks, Marion, again for inviting me to speak.
Thank you, Wong. We'll move on next to Leocarlo.
Hi, everybody. Well, in my country, the situation is a little bit different because we have a late situation of this pandemic. The first case in Indonesia, we found it at the late February, if I'm not wrong, late February. So as you can see here at my presentation, you can see my PPE, that it wasn't a PPE at all. It's a raincoat because we're not ready yet to face the pandemic from the first time. And what we did as a pediatric surgeon, so since we found the first case of the COVID-19 at my country, our collegium and our society make a, let's say, issue to cut off all operation, especially the elective operation. Because you know that the population in Indonesia is very huge, number 4 in the world, I think, 260 million population. So if I assume 50 to 60 million are children, we only have 130 pediatric surgeons. So the situation is a little bit confusing at the time because can I see the next? Okay, the situation because no before, sorry. So the situation is at the time is a lot of hospitals, especially at a big city, converted into the COVID-19 referral hospital. So the children that need to surgery, they have to looking for the other hospital that with a lower class hospital. And for a pediatric surgeon like me, because the lack of number of pediatric surgeons, the children didn't get the pediatric surgeons at the time. Slide, please. Can I see the slide? Okay, I think that's the situation in Indonesia for this pandemic. Hello, can you hear me?
Yes.
I think that's all for a while.
Thank you, Beda.
Good evening. Good morning to some of you here. I'm Dr. Beda from the Philippines, and I like to report that, like Indonesia, we have one also of the highest numbers of COVID cases here in Southeast Asia. And at present time, as of this moment, we have about 20,000 positive cases and almost 900 deaths. And less than 1% though is our children. But it's very sad to inform you and very unfortunate to inform you that one of our past president, Dr. Leandro Resurrection, and the present chairman of the Department of Surgery of Philippine Children's, where I work, is one of the casualties. He died 2 months ago because of positive COVID complications. So I think I enjoin everybody to remember him and leave a safe prayer. So regarding my slides, I think most of us are doing emergency and urgent surgeries. So definitely there will be a backlog of major elective surgical cases, not only in our hospital, but also in other children's hospital. And definitely the residents or the fellows who are in training will definitely suffer because there will be less cases to do, less surgical operations, and definitely the trainings of the programs will suffer. So this is a consequence of this pandemic. And up to this present time, we are not yet sure if we will open and we will do some elective cases. So we're hopefully praying that maybe next month everything is okay. We have the proper setup of the hospital and also the training testing kits. We might be able to do elective cases. So in some hospitals, low and general surgery, they're already opening for elective cases. So also another part of my slide is there will, of course, a limited number of outpatient clinic that we see. So not only in private patients, but also in the service cases. So again, they're down to the number of cases that our residents, our fellows of surgery are definitely experiencing. And we have 3 fellows at the hospital. And I think if this will go on, maybe there will be less cases that they will do. And lastly, last of my slide is that we are an advocate of delivering pediatric surgical care and community surgical missions to underserved areas and rural areas. And definitely this will be put on hold. So I think our program for outreach program will definitely suffer. So I think these are the major challenges that we have to face as in children's surgery in our local setting. Thank you.
Thank you, Dr. Beda. And from GIGS and all of us, our condolences for the loss of your loved ones.
Thank you.
Dr. Lubna?
Thank you so much. I'm representing the Pakistan side of situation. So as you all know, with the ORs being put onto a low priority with most of the resources being directed towards the critical care and ICU and COVID units, we really had initially underworked surgeons without much to do. At a time when the anesthesia team were being pulled into all the critical care units to help support the ICU and the ventilated patients. And therefore, we were given very limited OR time to deal with the emergency and urgent cases only. And as rightly pointed out earlier, this is leading to a huge backlog of cases, and we haven't even begun to start normal operations yet, because Pakistan is now on the trajectory of achieving its surge. The situation is quite dire here now after all these months. So this backlog is only going to increase with time. We did not have a negative pressure OR at the facility that we work in, and one was created for us. An existing OR was fitted out in a very short period of time, which was very helpful. The number of patients were low, to a large extent because of geographical access during the lockdown. And those that were presenting were often late presenters. other smaller facilities in the city had closed down, and therefore we were getting a lot of emergency cases. But again, they were coming to us late after having been refused by a number of other facilities. The COVID status of patients was a big problem, and sometimes the test reports took as long as 24 to 36 hours in the initial phase to come. We've now brought that time down to 12 hours, but until we know the COVID status of the patient, putting them into the appropriate unit or deciding to do or not to do surgery becomes a problem, especially in cases of emergency surgeries. And a big issue is that every child is accompanied by an attendant, and the attendants often change during the course of a 24-hour period, and definitely during the course of an admission. So the COVID status of the attendants is not known, and therefore we are at a constant risk of infecting others in the ward and the providers. Next slide, please. From the viewpoint of the providers, which is us and our colleagues and staff, the information was evolving. We never, because it is a new virus and a new disease, the rules and the SOPs and the information kept changing as we went along. There was a genuine fear amongst us of infecting family members as we were going home every day. And then the biggest reason why the providers were being infected was not during the hospital hours, where we were being very careful with PPEs. Our facility did not have a problem with adequate PPE equipment, but other facilities in the country have had a problem. And that community transmission, as the cases have grown, getting infected at homes, during transport to and from the hospital in our special transport buses that have been provided, have remained a problem. A lot of our drivers tested positive, and 8 to 10 doctors and nurses in those vans tested positive as a result. Next, please. From the patient's viewpoint, during the lockdown, accessing the facility was a huge issue, especially those people from rural areas. Our oncology patients, for example, their chemo schedules have been completely messed up and they've not been able to come in. There's been a lot of misinformation and a lot of stigma associated with COVID, and that has been a huge barrier in the way that people have been willing to disclose even their contact history. And because of, well, in Pakistan in particular, we had an issue between the provincial and the federal government, one pro and the other opposing lockdown, for example. There was a lot of confusion and lack of clarity, and that has really led to a very confused public. So I think clear messaging, not only from professional societies and groups, but the political leadership is extremely important at this time in helping us address this with a unified front. Those were my brief comments. Thank you.
Thank you, Lubna. Move on to Risha in India.
Thank you. I'm Risha Madri from Vellore in India. So in terms of the total population of India, and especially our district, the effect of COVID-19 was very minuscule. We had just about, till now, 25 cases in a population of about 2.5 million. So it isn't the COVID-19 which actually caused problem for us. But we had a very rigorous and very early lockdown starting sometime around 24th of March. And that actually is the reason why we had the problems that we are facing. And also probably the reason why we had so little issues relating to the COVID as such, and very few cases, because each district has its own administrator and they very tightly control who enters, who is allowed to go out, and how the lockdown is maintained to prevent spread. So the issues that I faced, and therefore I'm speaking mainly about my experience, are the prevention of treatment of regular orthopedic conditions because of the lockdown, because the patients were not able to travel. All operations that we had been doing were either emergencies or tumors, and some patients who actually had undergone surgery just a week or 2 weeks prior were unable to return home after operations. So they've actually faced financial problem, for which the institution as well as our district collector made arrangements both for food and their accommodation. In addition to this, the minor trauma had a slight increase because almost all those who fell were at home because traffic accidents were practically nil. And because the nearby private hospitals were closed, they came to Vellore. These statistics that I show you are for the 2 months for a single consultant, that's me, during the period of lockdown and a corresponding period in 2019. So you can see that these are the pre-appointments, that is booked appointments, and you can see that itself is almost like 25% of before. And if you look at actual people who were able to turn up for their appointment, it is less than 5% of what we saw in the last year for those 2 months. So most of the patients were not being seen, especially the new patients. Almost none of them were seen. And those who were not seen, we actually sent SMSs to every patient, giving them a phone number to call us. Even then, we were able to see only about another 25% of them by phone, but few we were able to advise them and get teleconsult done for them. Many was resolved over the email. And we found that many children, especially those with congenital anomalies, they are the ones who were not able to come. And the first visit for a clubfoot, like as I have seen happening after 2 months, or another congenital anomalies happening after 2 months. Could I have the next slide, please? So most challenges in my situation were related to inability of patient to follow up or to have the elective operations. There were excellent protocols for anesthesia, for how many of us should be working at any one time, for the PPEs, and all things were facilitated both by the government and the institution. So those were not the issues. And institution also responded to our requests, and we were actually, they were mass SMSs sent out. Telemedicine was arranged for us. And in addition to that, we actually were able to contact local doctors and guide them by phone, because many patients required a second stage surgery, which had to be carried out timely. And these doctors were able to carry out surgery, were able to courier medicines. But still, as you can see, only 5% of the patients were dealt with compared to last year. So we don't know what exactly is happening to the other patients. Are they having complications? Are they going to turn up with these plasters on their legs after 5-6 months with not being taken care of? That is our major worry. So it's how many of them will be missing care is what worries me, and how many of them will come with late complications is what I think is going to be our major challenge. Thank you.
Thank you, Vrisha. Go to Tamina.
Hello, hi. Greetings from Bangladesh. We are now passing the stage 4 transmission at the moment in Bangladesh. Earlier, when the first and the challenge that we face is the panic about the COVID infection, because we thought that Europe and North America, they have very excellent health systems. And when our people and even the doctors, health professionals saw that the death toll and the infection rate is rising so rapidly, they were panicked. Everyone is panicked. The patients, they didn't come to the hospital, they didn't come to the doctors. And the health professionals, they were afraid of seeing the patients. And we thought that because we were in a warm zone, tropical zone, we will not have this type of problem in our country. But now we are facing it. And the next challenge that we faced is educating our people. Wearing masks, keeping social distance, the 3 feet, 6 feet, it's very, very difficult. We, like in my, when I saw the patients earlier, the parents were bringing their babies, holding in their laps or in their shoulders without wearing mask, not themselves, not even the babies. And it's very difficult to educate them. And the next challenge, which was actually a very big challenge, is loss of livelihood of our on the daily workers. Our poverty level was before COVID was around 20.5%, but after COVID infection, when the lockdown started, our new poor we had another 22.5% new poor has been added to this 20.5% population. And loss of livelihood of the parents had a very deep impact on the children. We had, during this period, we had Ramadan, the month of fasting, the day of Eid, where children expect that they will have new clothes, new toys, new shoes, everything, new, very good foods, but the parents were not able to provide to them. Besides the health, because we have heard from my previous speakers, you have heard about the health problems, but this is actually a very big problem, which is why our government has a dilemma whether to open up the unlock the lockdown, but because of the demand of the people, if they are saying that if they cannot eat, they cannot feed their family, they will die. They have the option to die from the COVID infection. So that's why our lockdown has been taken off from 31st May, but infection rate has now going up. And in Chittagong, where I stay, the hotspot is now very in Chittagong. We are losing our colleagues, doctors. This morning, I lost one of my students. He used to work in the emergency department. So these are the three challenges that we have faced besides the problems that has been spoken by my previous speakers. Thank you.
Thanks, Tamina. And again, condolences from the GIGS team to your loss. Dr. Sameh?
Important forum. I am from Egypt. I'm Sameh Shahata. In another perspective, I might transfer what information is gained through this forum to the whole world in pediatric surgery, as I'm representing the WFAPS as the current president of the World Federation of Pediatric Surgery. So speaking about Egypt population, as you know, it's 100 million. The incidence so far of confirmed cases is around 30,000 cases. The mortality is around 1,000. We are still reaching to the peak, I think. Still, we have rising numbers, even especially in the last few weeks. But I hope we'll overcome this to a plateau or come down in the recent future. We have many problems, actually, as you can see from the table here, that this is from my center in Alexandria. You can see we are a busy center, around 320 cases per month, including majors and minors. This came to almost 1/4, which is 75 cases per month, exclusively for emergency cases only. So all the electives have been reduced or shut down, which actually is a major backlog of a waiting list for an important service that we need to provide. This is a breakdown of cases, admitted cases, operated cases, mortality. We have increase of the mortality because of the reduction of the total number, not because of an actual increase in the mortality. Next slide, please. So we have these are some of the challenges. This is change the uses of all facilities to emergency only, and redeploying the staff to face the pandemic, cancellation of elective and non-urgent surgeries, cancellation of a lot of outpatient appointments, and this is compensated by the use of virtual clinic, online consultation, and a lot of video conferencing tool to finish administrative and educational activity. Of course, we need to provide the PPE for all the staff. We had actually confirmed infection of 300 medical staff around the whole of Egypt. This is becoming really a serious problem. And this is a slowdown of training programs, ensuring the safety of medical staff and provision of PPE, and withholding, of course, specifically endoscopy and minimally invasive surgery cases because of concern about transmission of COVID. Next. That's all as far as the challenges are concerned for the COVID in Egypt. Thank you very much.
Okay. So, good afternoon, yes, everyone. This is Soji Ademuwa from Lagos. Majority of the challenges that I'm going to highlight have already been taken by previous speakers, but I will just highlight the specifics with respect to Nigeria. Like others have said, the surgical workload has gone down very seriously. It has impacted us to the extent that only emergencies and urgent cases like cancer cases and urgent cases like biliary atresia, for example, are those ones that have continued in this pandemic. For us at my center, the clinic has been shut down for close to 2 months now. They are yet to reopen because of the lockdown in the country generally, and particularly in Lagos, being the epicenter in Nigeria. Lagos accounts for about 50% of the national average. Nigeria today has about 11,000 cases, and Lagos has close to 6,000. So because of that, there has not been reopening of the clinics yet, but as the ease of the lockdown continues, hopefully our clinics will open. The other thing that has impacted us is that online training has increased. So there have been increased use of technology. So things like Zoom, like we are using at the moment, and other platforms to communicate and to conduct trainings and seminars have gone up. However, the corollary is that the physical hands-on has reduced, primarily because of reduction in the workload, and also because in COVID-19 settings, people who are not very experienced are excluded from theater. So house officers who are not necessarily needed within theater are no longer there. So it's only those who will actually be involved in surgeries that are allowed into operating rooms and to perform surgical procedures. This has impacted on residency training as well as undergraduate training. As a matter of fact, in my school now, the school has been shut, and we are not sure yet when they will return back to school. So because of that, we have not been able to have the usual training for both undergraduate and postgraduate. Lastly, the other thing which I would want to mention here is consciousness of safety. I think the COVID-19 has brought up the issue of safety first, safety second, and safety third. So now everyone is looking out for his colleague. You make sure many a times we try and put a call through to each other. How are you doing? And of course, apart from the emotional support that we give to each other, we want to ensure that in the use of PPE, we ensure that there's nothing like being in a hurry when it comes to appropriate application of PPE. So everyone is looking out for each other and making sure that all safety precautions are taken. I think I'll stop here for now. Thank you.
Thank you, Soji. We'll go on to Comrade Lawal. Are you done?
Thank you. Yeah, thank you very much. My name is Bumi Lawan from Nigeria. I'm a pediatric nurse. It's nice to be here. And I want to say thank you to all the nurses all over the world who have joined this discussion. So for us in Nigeria, like the last speaker have said, is COVID-19 has really imposed a lot of challenges to us as a country of over 200 million people. So right now we have the confirmed cases of 11,166 cases. Our discharge is about 3,329. Then our deaths is about 315. Again, it's also important. Now I'm looking at the first bullet there, the priority shift. So again, the infection around the healthcare professional is about 113, and they are still updating the data. 27th of February, Nigeria announced the first case. 27th of February, 2020, Nigeria announced the first case. And ever since then, it has been a lot of challenges for us as a country because there was this sudden, drastic priority shift. And priority shift self-imposed because you now see people at the community level refuse to even go even after knowing the symptoms and what they look out for. So you see some of the community even hide their own people who are affected are supposed to come to the facility. Again, that's increased the risk of healthcare professional where people sneak into the healthcare facility without disclosing their traveling history, without really being truthful about their contact. Then the government's influence, immediately after we confirmed our first case in 27th of February, the priority shifted immediately. Now, nobody is talking about immunization, nobody is talking about breastfeeding, nobody is talking about a lot of issues that promote health and well-being of the society, especially the children. Now we have a lot of stakeholders. We have the National Task Force who discuss around COVID. Nobody's talking about pediatric surgery. Nobody's talking about newborn. So there's this sudden shift of priority that really is a negative impact, that has a negative impact of the life, of the health and the well-being of the citizen of this country. Then of course, we've talked about the cancel of elective surgery. Surgery is an intervention to save life. Again, now we have canceled the elective. So we cannot tell complications after the cancellation and all the likes. Lack of funding. Now the government has, the Nigerian government from the national to the state level have a lot of donations from the partners to philanthropists, billions of that. Again, none of them is being channeled to pediatric support or pediatric health. So everybody's just talking about COVID and COVID and COVID. It is paramount, but again, because of the lack of intersectorial approach, that has really imposed a negative impact on our citizens. Then there's the lockdown. People have talked about the lockdown. The difficulty in accessing children's surgical care is really enormous because of the lockdown. People cannot, our patients cannot move from state to state. It's even difficult to move from one facility to facility. So it's a big problem. We make a call and we discover that, of course, women still put to bed, there's issue of congenital anomaly, but there's no care. So they just tell them, go home and come back after COVID. So what happened? So those newborn will just go back. The baby will just, the caregiver will take the baby home and they will just quietly die. Again, there's no system to really track them. Then patient rejection, of course, especially the private facility reject patients now because they don't have, they are not accredited because in Nigeria, before you can treat a COVID patient, you must be accredited and certified. So because of some of our private facilities who are not accredited, they cannot treat. So they lock down their facility. That again has also not been helpful. insufficient PPE, we all know that globally there's insufficient PPE. However, the PPE we have is majorly concentrated at the central, the Lagos, the Abuja, the Ogun, and the likes. But at the state level, the secondary level facility, we still face a lot of unequal or distribution of PPE. Then for technology application, I know like the prof said earlier on that, yes, we use Zoom, but hardly will you see a Zoom or online meeting that talks about pediatric studies, just very few. And I want to appreciate GIGS for bringing this on board. And again, we know about e-health, the telemedicine, the telenursing, and all of that. So finally, yes. Okay, finally, okay, thank you. Finally, I just want to say that there has been poor training when it comes to boosting the skill of healthcare professional on the care of pediatric surgery, advocacy the fear and the death among the healthcare professional has really served as a big issue for us as a country ever since the advent of COVID-19. Thank you.
Thank you very much, Bumi. I think one of the answers to your main punchline questions is that children have been less affected, but they are collateral victims of this disease. So I'll move on to Dr. Nabulindo Suzanne.
Yes, thank you very much. Susan Nabulindo, pediatric anesthesiologist from Kenya. Again, most of the challenges we have gone through are probably shared with the rest of the countries that have presented. So just a bit to show where we are in Kenya in terms of the disease. The graph there shows the distribution of our cases in terms of age and gender up to today. So we can see that we have a very small number of children. So far in total, by yesterday, we had 2,216 cases, but only 20 cases of children. And in children, so far, we have had 94% of the children being asymptomatic. We had one child we lost a few days, just came to the hospital quite sick, had other comorbid conditions and passed on. Results for COVID came out positive. That is the only child we've lost. Most of the children who are in the hospital now are basically asymptomatic. Important to note is that we had one child who had undergone surgery, was asymptomatic, but just because of being tested in the ward, actually turned out to be positive after people had handled the child without any precautions. And that actually brought us to become more cautious from that time. Thank you. Next slide, please. Yeah, so what has the COVID-19 pandemic done to surgery, pediatric surgery in Kenya? So the first case was announced on 11th of March, and in the same week, the Ministry of Health gave a national-wide directive that elective surgeries should be stopped. Emergency surgeries, emergency surgeries and urgent surgeries continued, but there are some small facilities in the periphery of the country which were completely closed. So patients who are usually seen there needed to travel to where they could get help. And we have seen some children traveling quite long distances looking for emergency surgery. Then there was partial lockdown. Partial lockdown here, I mean that once the government, with the continuing testing, once it was confirmed that the community spread had started, 2 big towns, the capital city plus the coastal city, were locked down so that nobody could move in and out of the those particular regions because they were seen as hotspots. So in the first week of that time, there was a lot of fear because the police were handling people quite roughly. So patients were afraid to move. But luckily, with the announcements on media telling people that if you are sick and you needed help, then you are allowed to move. with the barrier so long as you had a letter. So this again helped a bit with making the people look for, parents look for help for their children. But initially there was a lot of fear of movement, which hasn't 100% gone back to normal. Then there's the issue of delayed presentation for surgery. This probably around issues of stigmatization of the disease. People are afraid, first of all, of moving with the security people handling them. Then there was fear of being tested in hospitals. And the way it has been happening is that when you are tested and you're found positive, you're basically taken to an isolation center. So, and in the media, there was all going on how people are being handled with contact tracing, all your family taken away. So people are afraid of coming. So those who are coming to hospital are coming when they really need it. So you see children who are being brought very late in surgery. Then their parents are not seeking surgery for elective problems. So the clinic, like at the referral hospital where I work, the pediatric surgery clinic was never closed. Basically continued running the clinic, but the numbers dropped to 20% of the number of patients they see usually. That has now improved a bit. We are probably at about 40%, not yet doing so much well. The other cases that were being done again is the urgent surgeries, especially tumors. Probably that was a good thing for these children who have been waiting for so long, especially we have a lot of burden for Wilms tumor. We've done quite a number of that during this period. So that group of children probably benefited because now there was theater space for them. Then you have strategies that have been used. Emergency cases have continued throughout, and slowly, more of the hospitals in the country have actually opened up and they've been working. So talking to colleagues from all over the country, there hasn't been a problem with emergency cases. The only problem has been the time the patients take from home to the hospital. Healthcare worker education on infection and prevention control for COVID-19 has been going on from the start. And it has been a slow uptake. So you would go into the OR and you find that there are people who are using PPEs. The anesthesia group were very early in picking up that, but the rest of the people in the group will still be lagging behind. But that has been a challenge which we have tried to surmount slowly with education. Then departmental guidelines, the Ministry of Health again went out has been giving guidelines for most of procedures around patients, but also departments and hospitals are encouraged to form their own guidelines on handling the patients. And that has also helped quite a bit, but again, that has been a very slow process, especially in places where people are not used to working with protocols or guidelines. So they have to, but with the technology, Zoom, webinars, people are learning from each other. The public education through media, through the Ministry of Health, has been going on and it has improved. So initially when people are not really coming to hospital looking for help, the message—
You're gonna need a punchline.
Yes, yeah. So and lastly, the challenge we are struggling with right now is that our numbers are going high, but this Monday, the Ministry of Health announced that elective surgery should be open. They gave a guideline, but all hospitals still have to make their own guidelines. So people are grappling with the fact of what will we do? Are we going to test all patients coming for surgery? So that is the challenge we are actually facing at the different hospitals right now. So by next week, people are expected to open up.
Thank you very much. Our last speaker is Fabio from Brazil. Welcome, Fabio.
Thank you a lot for this invitation. I hope that everybody can hear me. So first of all, I'd like to present you some numbers of my hospital here where I work. This is a teaching hospital from one of Brazilian states. What you could see that during this social isolation time, we decreased a lot our number of surgery by almost the half of the procedures. And what is our concern is that if you look for the emergent procedures like appendectomies, the number is still the same. There is a decreased use of laparoscopy, but this is the thing that we have more concern. The length of stay is increasing. Next, please. So if you can see this, next slide, please. If you can see this graph, I think that with more few patients, we are going to prove significance that the length of stay for appendicitis is increasing. And we think that because the Brazilian families, they have this fear to take their children to the hospital because we fear to get the COVID inside the hospital. So the number of incarcerated hernias increased, the number of test distortion that we lost the tests also increased. This is a research that we are conducting now, and I hope to present to you soon. Then I would like to say about the Brazilian situation. We did a survey with a partnership from the program Global Social Change from Harvard. We surveyed 64 Brazilian institutions where pediatric surgeons work, and they said that the majority of them, they modified the preoperative management. They are using more imaging. They are using more clinical observation before deciding about the surgery or not. And we can see that over 60% of them decreased the use of the laparoscopy. Next, please. 98% of these Brazilian institutions have postponed elective procedures, but the major problem is that the pediatric surgeon said that they didn't receive any kind of list of priorities of which kind of surgeries they should or not postpone it, and this was a really problem. Fortunately, here in Brazil, we're not having PPR shortage. Like you could see that more 90% of them said that they are using. But what we do have a problem is the pre-op COVID testing. So testing in Brazil is really bad now. And I think that is also a challenge. Next, please. So just to summarize, I think that these are the three major challenges here in Brazil: the poor availability of COVID-19 testing. The second one is that Brazilian families are really having this fear of going to the hospital. So as Dr. Kokila said, this collateral effects on children is being noticed here. And there is a huge lack of consensus on which surgery should be postponed and for how long, because we started the social isolation since Europe in March, and then we are crossing the curve now. So it's getting hard to stay with lockdown, and this measure is for more than 3 months. So thank you very much for the opportunity.
Thank you very much, Dr. Fabio. We'll now move on to the discussions where questions will be tackled by another GIGS team. Thank you.
Right, so thank you very much everyone for sharing your experiences with us. So we are going to circle back to every speaker with a few key questions from participants. So I'm going to start with, so Doru, can you bring up the questions starting with Ken?
Sure, Dr. So everybody please filling in the chat box with questions and answers. So one of the questions, Dr. Wong, to you early was how to pre-op, whether or not you're pre-op screening for COVID, for elective cases, and what you're doing with caregivers. Could you comment on that?
In the beginning, because there's a lack of sort of a proper sort of testing kit for the general sort of public as such. So we're only selectively testing patients with symptoms like fever, unexplained fever, that's it. And with hindsight, we probably should have been doing all of them, because now with more research, we know that the patients with the highest infectivity of the virus are those patients before the symptoms start. So in a sort of like ideal world situation, you should be testing everybody. The problem with PCR, it takes time. We're looking really into faster testing, turnaround time about 1 to 2 hours. That would be great for everyone.
Okay, thank you.
Questions for Dr. Milano?
Hello, yes.
Doruk, are there any questions for Dr. Milano?
Not specifically, but Dr. Milano, maybe you can comment on how you're dealing with the collateral damage of the backlog. What do you think should be done from the collateral damage that, not from the direct COVID, but from the backlog in your setting?
My setting, yeah, you know that there's a lot of canceled operation. There's a lot of postponed operation. So we have to make a, you know, sometimes we make a teleconference with the patients, and just told them that not all the patient should be operated at this pandemic. So we made a community. We made a community at the patient, for the patient. Usually like that. That happened in my institution right now.
Thank you for that, Dr. Milano.
Welcome.
So for Dr. Espineda, Doruk, are there any questions?
He's answered quite a few. Really about also how to, maybe he could comment on how to prioritize cases, what to do, what not to do.
We were talking of possible elective surgeries, or because at present time we are not yet doing elective surgeries, only emergency or training cases. So the priority, of course, is cases that are neonatal surgical patients, which because our children's hospital is a children's hospital, and we have a very good neonatal unit and ICU unit. So rather than referring to us some patients like appendectomies, obstruction, and the like, we would prioritize that we will accept more cases that are within our realm of scope of surgery, like neonatal surgical cases. But maybe if and when we open the elective surgical cases in the near months in the future, we will have perhaps do a very strict guidelines. But although there is a guideline from the American College of Surgeons and also from our local surgeon society, but I think it will not be, for me, applicable to each hospital. It will be on institution base because of the many limitations. Like in our hospital, our problem is the PCR testing. Our colleagues from the infectious disease unit, which are composed of infectious specialists, they are suggesting or recommending that if and when we open for elective surgery, then they would suggest that patients will undergo PCR testing as a mandatory or routine procedure, which some of our colleagues are not agreeable. So maybe we have to sit down and do some, because here in our country, in the Philippines, the PCR testing is the gold standard, of course, but it's a very prohibitive cost, and the hospital will not be shouldering the expenses. Neither the health insurance will be shouldering this one, and this will redound to the expenses will be shouldered by the patient, and I don't know if this patient can afford this one. The testing will also be done also for the health workers on a regular basis. So I hope I answer your question.
Thank you.
So Doruk, what's the next key question? Not necessarily to any particular person, but what's the next key question?
Yeah, there's a question from David Cunningham from Kids OR to everyone. thinking about the backlog of patients that's building up, if you were speaking to a donor and telling them how they could help, what would you ask for? I think that's for any of the panelists.
So Dr. Samad, can you help us out there? Can you give us your thoughts on that question?
I think the backlog is, and if I understood your question correctly, how can we get donors to help in with the backlog of cases? Is that correct?
Yeah, if you were speaking with a donor about the backlog, how could they help?
Well, I wouldn't speak to a donor about the backlog of cases because the solution is not really in the restricted to the funding challenges. The solution has a lot more to do with the situation that the country is in, the infection rate amongst the providers, which is a real issue in our situation. So the financial or the donors are not the solution to this particular aspect because it's intermingled with so many things. The only way I can possibly see donors being involved is that if for elective surgeries we were to have international teams come in or increase the capacity locally and try and do camps, etc., to address the backlog. But with the travel situation, that's not going to be possible. So I suspect each country has to figure out what is the right time to increase its own, to start delivering the care it used to and how to ramp up and fill the gaps. Now, the practical challenges that we face is that as the lockdown eases and patients can access facilities more easily, the cases are increasing. And therefore, not only are your beds being taken up with the COVID patients, but your staff is being affected at the same time. So we're in a bit of a catch-22 situation. I, for one, would certainly not go to donors to solve the problem. It's so much more multifactorial.
Thank you, Dr. Samad. I think still with regards to that question, because it's so key to us, Dr. Shehata, especially with your cap as WOFAP's president, what would be your thoughts regarding that question?
Well, it's a difficult question because it all depends on the policy or national policy or regional policy about reopening. This is the only way. But again, the donors can be contacted in this aspect if they can provide the PCR kits needed to implement a safe reopening of some of the cases that are needed for surgery. And your other question was how to prioritize the cases. Of course, you mean the elective and not the emerging cases, because the emergency cases are already priority anyway. But if you are talking about the elective cases, I think it is the work of national organizations like the JECs or the WOFAPs to put a consensus or guidelines on how this is an unprecedented situation. So we need to put a way, an algorithm of how to choose cases when we start reopening. You cannot operate on all cases. So what are the choices? Are they indication dependent or age dependent or on otherwise? So maybe it's the work of JICS or the WOFAPs or many international organizations together to put a consensus on what is the priority of elective cases when we start reopening.
Thank you very much. So obviously this is an aspect that as GIGS will still have to come back to and do a little bit more work on that aspect about how we work with donors to sort out the backlog. Doruk, next pressing question.
There are some comments on the impact on resident training and any solutions that have been implemented to the impact on education.
Thank you. Dr. Maduri, can you give us your thoughts on this aspect? Is Risha still on? Tamina.
Hi, sorry.
Risha.
I started talking without switching on my mic. So in our country, we have seen a very large number of webinars being organized with, actually, we are able to get much more national and international faculty to participate, because many of the pediatric orthopedic surgeons are pretty jobless at the moment because of the lockdowns. So we have had almost every week, we have 2 to 3 webinars on different topics which are taking place in the field of pediatric orthopedics alone. In addition to that, there are a number of webinars which have started on other areas, like teaching about the COVID, about the precautions to be taken, training for COVID, and this includes from our society, the Pediatric Orthopedic Society, as well as regional other orthopedic societies. In addition to that, institution is carrying out a number of webinars which allow you to learn new techniques. Like there was a series of webinars on how to use the Microsoft program for doing teaching on within the department. So you could, in our institution now, all meetings take place with everybody sitting on their own computer terminal, but similar to what we are doing on the Zoom right now. So actually a lot of teaching has gone on, and it is possible provided one uses these resources.
Thank you, Dr. Botelho. From the South America perspective, can you give us your take on that question?
Yes, sure. So here what happened is the residents and the fellows, they were very afraid to not have the proper training during this time and miss surgeries. And so we give them the opportunity to not participate in the service, but they prefer to stay with us inside the hospital to try to train as much as they can. So I think that for the residents, what we have to say is to talk with them and giving them the options, but I also think that if they would like to help, they are welcome. So.
All right, thank you. Duruk, are there more questions?
Maybe a question about any violence or stigma against healthcare workers and how that's been mitigated.
So we'll come back to Tamina, from the Asian perspective. I know this has been such a serious issue around the world. Is Tamina still on?
Can you hear me?
Yes, we can hear you now.
Okay. So there is a stigma, like I said in my presentation, that the panic that it's like getting COVID infection and treating them. You are sort of, we call them low caste things like that. So for the health professionals, there are some incidents that happen that the landlord forced the tenants to evacuate their house. Some of the people were forced to leave their place in the villages. So our administration has taken steps. There are laws has been, regulations have been made that if somebody does that, also there is a very bad situation during the funeral of the dead COVID patients. They thought that it will, the dead body will infect everyone. So even the family members, children, they don't go to their parents' dead body. So government has taken some steps, and these situations are now being a little bit improved.
Right, thank you. Dr. Ademuyiwa, do you have issues with stigmatization in Nigeria? And if so, how have you mitigated this?
Yeah, there are issues with stigmatization, both with patients and anyone that has, even before being labeled as COVID-19 positive, just for the fact that you are in a isolation hold-up, while awaiting your results, people are already running away. How we have mitigated against it is enough education, as well as advocacy. I think the Nigerian government through the NCDC has tried a lot to educate the people. I think the media too, both the social media and the mainstream media, has also tried through lots of jingles to try and educate people. Number one, that COVID-19 is not a death sentence. And secondly, many of the myths around the disease that are not true are being debunked. And I think with time, more people are now open to the test with these interventions.
Right, thank you. Bumi, I know you work a lot in the community, in the various communities. What are you seeing with stigmatization and how is it being addressed in your area?
All right, thank you, Professor Ame. The issue around stigmatization is actually huge within the community setting, because once the community members, the people, knows or identify a patient being treated for COVID-19 or even coughing alone, you will see community member running away and they don't want to talk to that person. You see whereby a woman just abandon the man at home like that. So there's a lot of stigmatization. But for the healthcare professional, particularly the nurses, you know, because we have inadequacy of nursing, we have a lot of volunteers. And once you volunteer to manage or to treat COVID patient, they will give you separate facility to stay. You don't go back home. So we even have difficulty to get hotel facility for our nurses to stay where they treat their patients. So there's a lot of stigmatization. Like Professor Muiwadi said earlier on, the government is doing a lot around sensitization. Then now we engage the gatekeepers. We engage the traditional rulers. We sensitize them so that they can pass this message around to support them, to increase this community acceptance of.
I think what we're running out of time, we're going to move to the next section is we want to know from the panelists and also from the discussion, how can gigs help? So I think if people can put in the chat, how can gigs help during this period and what are the priorities going to be? And I'll hand over to Emmanuel again.
Right, so thank you. So we are circling back to each speaker again. We need to quickly hear from you how you think we can all work together as gigs to move forward on this. So we'll come back to Dr. Wong.
I think having regular sort of meetings like this, where a lot of people can participate at the same time, can certainly spread sort of information amongst different people, all the healthcare workers and the people who even from the policy makers. So, you know, things that we publish in a journal, not people will read about it. Whereas in a virtual meeting like this, you know, many people can attend. So it's definitely helps. I think Marilyn was saying about having another similar meeting in a couple of weeks' time, which is definitely going to be a great help. That's my opinion.
Can we keep the answers short so that we can go through the whole panel?
Right. So Dr. Milano, just 1 minute to let us know what we can all do as gigs.
Okay, thank you, Professor.
Shops near you.
So from my presentation here, our suggestion is we hope that gigs can issue a children's surgery consensus specific to the pandemic. For instance, is the pre-op screening for COVID-19 the same for newborns and adults, where it is mandatory to verify whether the patient has coronavirus or not through swab, PCR, or rapid test, even though the newborns are born from mothers that are confirmed negative of coronavirus? So I think this would eventually make the pre-op waiting time longer and would require PPE that would make the cost higher. So it is my suggestion for this.
Thank you, Dr. Espineda.
Yes, regarding the second question, I think we will continue to give more webinars or teleconference on topics, not only topics, but topics regarding these continuing global issues on COVID-19. I think we geeks should more or less, or members, especially from the low middle income countries, should have an algorithm or a protocol that more or less we can universally follow if it is possible. So for the residents and interns, I think we could, geeks could provide a teleconference for continuous studies and learning process for the residents, in as much as we can teach them manually during the time of this pandemic. And of course, the lastly is, we come from a low middle income countries, and we have very short financial support from our government regarding this kind of like PPEs, goggles, and the like. So if the geeks can, to the donors from geeks should also think over whether they could send us, if possible, some of these PPEs or other activities. Thank you.
Thank you. Dr. Samad?
Okay, so
Dr.
unmute.
Samad? Okay.
Yes, unmuted now. So I think shared experiences through webinars are very useful. This is just one way of us keeping in touch with a field that is changing very rapidly. And I think standardized guidelines that may or may not need to evolve over a period of time would be helpful. Again, I think there have been questions on the chat about neonatal testing and similar guidelines that, because new guidelines have been coming from so many sources, many of which are not applicable for LMIC settings. And it's important for geeks to have guidelines that are sensitive to LMIC context for them to be meaningful and to be adapted more easily. And again, I think rapid diagnostic tests that could possibly shorten this period considerably in terms of testing, patients, attendants, staff would really help us address and get ORs back up and running more easily. Thank you.
Right, thank you. Before the next speaker, I just want to emphasize that participants should keep their questions coming. We intend to compile all the questions, even those that have not been answered, and they will be answered later in an email back to everyone. So Dr. Maduri?
I feel that the gigs should work towards, in the next 1 year at least, we need to have a decreased footfall of the patients to the hospitals, and so that the ones who actually need to come to hospital should come and the others should be taken care of by increasing contact over telemedicine or in other ways. So I think this requires certain amount of research. We need to know how many of the patients actually need to come, which are the patients which can be dealt with over the phone or by telemedicine or by actually contact using WhatsApp and things like that. And the role of telemedicine in follow-up of our patients, so that review patients could be less. Actually, we may be seeing them 5 to 10 times more than the number of patients who actually need to come back, because patients like to come to the doctors, and if the doctors could be easily accessible over the telemedicine, then maybe this could decrease. And I'm wondering if we could have a large amount of data put in, and with the machine learning, we can find out which patients actually should be contacted proactively who are not able to come, and devise algorithms now for how these patients should be contacted, when they should be contacted. And also, I feel that this is what is going to happen, at least in my country. I think in the next 6 months, many of the patients are not going to be able to come. There will be travel restrictions in the hotspots. And if we could work out a way and algorithms on which patients should be made to come or which patients should be dealt with, that will be very useful. And I think GIGS could help by setting up some research studies which lead to these outcomes in all the countries, not just in India.
Thank you, Dr. Banu.
I think GIGS can help with the research of on impact of COVID on children from lockdown with the non-COVID problems, their resilience in this period. There are some positive influences like family bonding has increased. There are some appreciation of nature, and there are some hidden talents has been flourished like painting, writing, all those things. But there are also negative things like abuse, violence, those things. And of course, with the disruption of vaccination and schooling, what are the impact on these children? We can, GIGS can do the research about this.
Thank you, Tamina. Dr. Shehata?
Yes, thank you very much. I would like to congratulate the excellent suggestions made by all the panelists. I would like to summarize very quickly as you needed on 4 aspects, which is setting up guidelines for safe performance of surgery. This is a consensus not only the GIGS can work on, but again, this can be done in collaboration. We are working on one, actually at the WFAPS, we can join task forces and come up with a conjoint recommendation or consensus between the WFAPS and the GIGS. The other point is, I would like to highlight, Tamina has just mentioned the importance of research. We have at the WFAPS RedCap system available free for anyone who would like to conduct research or survey. It is a wonderful tool if someone doesn't know it, and we can provide it for anyone who would like to make a survey or a multi-center research. It gives you immediate statistical results upon collaboration of so many centers at the same time. So I'm inviting any one of you who would like to make a survey or a multi-center study on the RedCap. Of course, a lot can be done online, webinars, education, training. I can invite a consultant every week to talk to people from low and middle income countries, to young doctors who need advice. So this is organized by WFAPS or GIGS. Your expert of the week, he can talk in obstetrics, in anesthesia, in pediatric surgery, can talk to young doctors who need certain advice. And again, patient consultation can be made nationally or regionally under strict criteria of safety and reliability. Fundraising, of course, can be supported to provide PPE and PCR kits for areas of need. That's all for me, and thank you very much again.
Thank you very much, Dr. Ademuyiwa.
Right. I think GIGS has already started with this kind of program, and I think such program as this will be very helpful in the future to continue to brainstorm. The issue of webinars have been raised. I think the teleconsultation also for patients can be organized with GIGS volunteers being made available on the web to see patients, particularly those in remote areas, and to give advice as to next line of action. A very important thing I think no one else will do but GIGS is to have the kind of interactive website like the one that WHO has or the one that Johns Hopkins have. We hear how many patients have COVID-19, but we don't know the percentage that are children. And I don't think anyone else will be able to do that. And I think that GIGS can help to analyze that data and bring out children data out of the global data. And that can help to track the progress with respect to children. And then post-COVID-19, I think it's important to continue to have programs like this, particularly a lot of people need psychological and emotional support. We have had, even in this program, people who have lost colleagues, who have lost friends. And I think GIGS is a family. That's the understanding I have. We look after each other, and I think we should continue to do that post-COVID-19. Thank you very much.
Thank you very much, Bumi.
Thank you very much, Prof. I also want to say that GIG have a role to play, building better and stronger pediatric surgical ecosystem, coordinating globally the pediatric surgical services. That is key. So which means that we expect GIGS to provide members and countries reliable information and guidelines on the best practices, policy and standard, you know, for pediatric surgical services. One thing that remains that we've not really discussed is how do we ease out? Now that the lockdown affects the structure, how do we gradually ease out and undo the backlog? So GIGS should come out with a guideline or a protocol. How do we do that? Like Nigeria now, we begin partial ease out of the lockdown. So how do we do this ease out? Not just to wait until total call off of the lockdown. Advocacy is key. GIGS should please take the lead in advocacy for pediatric surgery all over the world. That is really pertinent, and we expect GIGS to take lead of that. Mentorship is key. So we expect that for countries, especially like ours, we need GIGS to give a lot of mentorship on how best we can handle our pediatric surgical services. Thank you.
Thank you very much. Dr. Nabulindo, in addition to telling us about what GIGS needs to do, there have been several questions about how you were able to decide to reopen for electives. So as you make your comment, we'd like you to say a little bit more about that.
Okay, thank you. We'll start by just answering that question very fast. The criteria for deciding to open up for elective surgery was actually made at the National Ministry of Health. So there have been discussions and looking at the trends of what is happening. So there is confirmed community transmission going on, but the government believes that they have contained a lot of spread, although we are having our numbers still going up. So it's still a worry for the healthcare workers. And then there have been discussions with the healthcare workers. Again, there are different opinions on people who want electives started and those who are still reserved. So Ministry of Health has advised every hospital to come up with guidelines on how to handle the situation. So probably gradual opening and putting up precautions of how to handle these patients in terms of testing, PPEs, because hospitals have been given time to prepare. And there's, I believe, and then there is the economic and the political side of things where everybody is talking about the loss of revenue, loss of jobs, and there's a push from the political and economic divide to open up because most hospitals are basically not working as it is because from the start, there was specific hospitals where COVID patients are being admitted. So the other hospitals are basically not working, nothing going on. A lot of healthcare workers are sitting waiting for patients. We haven't seen a surge yet. Our numbers are going up. Most of our patients are symptomatic. So those are some of the reasons that people, those who believe that we should open up, have gone ahead and say, let us open up gradually and see what happens. So in terms of GIGS helping, again, I'll echo the fact that we're using webinars for various of, to discuss various things as this brings out the information to more people, sharing the information we have on email, especially on guidelines and what is changing every day about the disease to make sure the patients and the caregivers are protected. Again, PPEs, most countries, as presented here, have not talked about having shortages of PPEs, but some of us are still on the upward trajectory. We don't know what will happen. Provision of it, strategies of how to minimize misuse and optimal reuse of PPEs can be things that GIGS can help everybody understand in case they get into a surge of many patients.
Right, thank you very much, Dr. Botelho.
So I think that GIGS and donors could help us, like first giving some material example protocols and education, like short videos that we can share in Instagram, WhatsApp to families and primary care health providers. in order to alert them about the warning signs of critical pediatric surgical disease. I think also that it's very important to encourage the research. Probably we can compare the bellwether procedures in pediatric surgery from these months to the last year. Then we can see how really was the collateral impact of COVID-19, because I think that probably we could not do a lot this year, but we have the responsibility for the next generations, because we didn't know nothing about how to procedure in this time. So I think that we have the responsibility if the next generation should face another pandemic crisis. And finally, I think that we should continue to support, especially for the donors, the PPA, but also the COVID-19 test. I think that would be very important. Thank you.
Right, thank you very much, everyone, for sharing your thoughts. So I'll hand over back to Kokila for the remaining part of the meeting. Kokila?
Thank you, everybody, for participating in this very, very dynamic platform. I think we heard all the voices and we heard some solutions, and we have a lot of enthusiasm of how we can take this forward. What I would say is that I think there's a voice saying out there that we need more of these platforms and work together taking this forward. I am aware that there are some grants that are coming up in the UK, and I thought it would be good to embrace the GIGS community to look at the impact of COVID on children as collateral damage is an idea that I'm just floating. And it will be something that we can all start working towards, because that would give us international impact on the collateral damage to children, because the numbers of COVID infection in children are not high, but the children are struggling and suffering due to no access, and also poverty in the community due to parents not having income. So these are thoughts we can build up on. I'd like to thank everybody, all the panelists, as well as Madeline for coordinating all of this, for Kitty for running this platform as well, for Zippy and Doruk, and mostly to Doruk, who came up with the idea to say we should have a webinar in GIGS. So I think this is not the first of the many that we should take forward. Thank you very much to all, and thank you, Doruk, for the idea.
Thanks, everybody.
Right, thank you very much. So Marilyn, any last thoughts, final announcements as we close?
Yes, I think I've been trying to scribble ideas, and I think I'll be sending out a follow-up email to all the participants and to the panelists and members of GIGS, sort of helping to summarize what we've come up with, and hopefully we'll be able to really consolidate everything and come up with some proposed interventions, and perhaps even direct some of those projects to funders. And there were a lot of common themes that emerged. So it's great to see everybody, and we'll stay in touch.
Right, thank you very much, everybody, and do have a good day and a good night.
Good night.
Bye-bye.
Thank you very much.